heart, lungs, and gut. We've always said that the lower part of the colon gets a parasympathetic supply from the sacrum, until a few years ago in 2016 when the paper came out saying that actually the supply from the sacrum was sympathetic. Now there's been lots of arguments about that. Whatever, largely the parasympathetic supply to your heart, lungs, and gut is from the vagus. And the vagus, like any nerve, has the possibility of irritation or entrapment points. Those entrapment points in particular are around the skull base, the clavicle, inferior medial clavicle, and the diaphragm. So we're going to talk about getting those moving. Now, let's go on to the next slide. This is a slide of the skull base itself, and we can see this is a real fetal skull base of about a 38-week gestation fetus, poor little thing. And you can see here that the occipital bone, this is your occiput coming forward round here. So this is a basilar portion, the condylar portion, the squamosal portion. It's in 4 parts. And right on the border here between the occiput, the condylar portion, and the petrous temporal, this is your jugular foramen. You can see the difference in size of these 2 jugular foramens of this little guy. So remember, what comes out the jugular foramen? And by the way, questions, guys, please post them. I'll be really happy. Anything strikes you, please ask, because I really want you to get something useful out of it. So what comes out the jugular foramen? You remember your cranial nerves 9, 10, and 11. So cranial nerve 9, the muscles of deglutition, cranial nerve 10, the vagus, parasympathetic supply to the heart, lungs, and gut, and cranial nerve 11, you supply to your SCM and your upper traps come out of that area. Also, we've got the jugular vein coming out of that area. So you've got 90% of the blood vascular drainage of the cranium coming out of that tiny, tiny little area. So it is really important. Basically, if the infant is stuck in an asynclistic position, okay, which is a position where the baby is side bent for a long period of time in the birth canal, we will tend to get a tissue strain where this approximates this. If you compress the occiput towards the temporal, or the temporal towards the occiput, you're going to inhibit the space in that jugular foramen. And that's where we can get issues, and they're particularly affecting the vagus nerve, but those other nerves as well. So what symptoms do we see from it? We see difficulty in swallowing or choking while feeding. You get babies who they feed, and then they start coughing or choking. Classic irritation of the, actually probably as much glossopharyngeal as the vagus. Digestive difficulties is where we really see it. So babies who are straining all the time, who are constipated, who are refluxing, who are vomiting, who have colic, who are screaming. And really my definition of colic, we won't go too far into this, but my definition of colic is really about an infant who gets screams, draws the knees up, and then changes pressure in their gut and gains relief of that. And the changes in pressure can come from vomiting, pooing, or the release of wind in either direction. That to me is probably really what colic is a pressure issue within the gut. And when that's relieved, they feel better. And those kind of issues tend to come from the vagus. And then, of course, we've got the potential for torticollis occurring from dysfunction of the SCM and the upper traps from the relationship to the spinal accessory nerve. So lots of potential issues from that jugular foramen compression that we see very commonly. So what are we going to do about it? Well, I'm going to go very briefly through 2 cranial techniques. We'll touch on another one as well. Those cranial techniques are to be done in an ultimately gentle way. So we're going to, I'm just going to come off the screen share at the moment so that I can see myself doing this, so you can see what I'm seeing. So what we're going to do is we're going to release the base of this infant's occiput. And to do that, we're going to create a very, very gentle traction test. So I'll actually be using both hands under that infant's occiput. I'm not going to have the infant standing on its head like this or anything, but the hands, the infant's going to be supine. And I'm going to try, my test is a very, very gentle pull here and seeing if the tissue has give, if that bony occiput will give a little. The pressure I use is equivalent to the pressure you tolerate on your eyeball. Okay, so really cranial work is very, very light. So it's a gentle pull and see whether you've got a pliability. And we compare left and right. If the left side is more restricted, that's the side I want to release. Now, the key thing is about cranial work is you run away from tension. Whereas when we're doing a spinal adjustment, we take it into tension, into the fixation, and we go through with the adjustment. Cranial work, we're stimulating slow stretch mechanoreceptors. We are going into the area of freedom. So if it's restricted coming this way, okay, we look going laterally, we look going medially, we look going inferiorly, we look in rotation of either direction. And all you're after is a tissue release, a little give as the tissue comes round. As it gives, you just follow it until it stops. We call it a tissue slide. So you follow the tissue slide until it stops, then look for the next direction. Is it lateral? Is it inferior? Is it a torque in the other direction? And 2 or 3 tissue slides are enough. You come back and you recheck the pliability. Pull and pull. Recheck either side. You'll often find the other side now feels really restricted, whereas the side you've been working on feels free. And that doesn't mean this one is been restricted by it. What it means is we freed up the other one, we've got to do this one as well, because usually you'll end up doing both sides. So then we go into the release of this side as well. And again, the emphasis is you run away from stress. If I show you what happens, this is fascial release. We've got restricted fascia. Instead of pulling it like you might do in an ART technique, which is great, but not appropriate on a baby's head, we look for the direction of freedom to unwind it, unwind it, unwind it, unwind it, until we get that pliability in the tissue. Once you've got the pliability in the occiput either side, happy days. You're going to have an improved baby. One thing I would say with this, guys, is if you're going to release the occiput, you also need to release the sacrum. And the sacral release is a really important thing. Now, I haven't put the slides in this, but I will put a slide or two of the sacral release because I'm going to give you a PDF of this afterwards to go up on the Facebook site. So, but I'll put the slide of the sacral release. We check the sacrum by squeezing the buttock clefts together. And we're looking for the side of deviation. Okay, any sort of deviation, we're going to then, the side of deviation is the anterior sacrum. You're going to hold on the posterior sacrum, stabilize the ilium, and stress the posterior sacrum from P to A. Okay, hold it, hold it, hold it, fast stretch it. That's a direct technique we're using there. So you want to get the buttock cleft in the midline. Once you've got that, then happy days, you can go up and release the occiput. I'm just going to go back into sharing my screen again. Okay, so so we can go back onto the presentation. So we're also going to look at temporal release. Now, temporal release is, we call it House of Windsor technique, where we're actually tractioning on the ears. We get hold of the ears and we pull a lateral traction. So they look like a member of the British Royal Family. I didn't say that. Okay, we traction laterally. Okay, and we see if there's a pliability, okay, in there. There should be an equal pliability on both sides. If there isn't, we go into the direction of freedom. Unwind it, unwind it, unwind it, unwind it. And follow it until we get equal pliability on both sides. You may be going superior, you may be going inferior, you may be going posterior, you may be going anterior. Just follow the direction of freedom. That will improve it. This is a generalized decompression you can use, and this is where you hook in the little sulcus behind the ear with the thumb, okay, here, and then you can just traction the maxilla on that side forward. You don't need to hook behind it, you can just have a finger in there and just traction it forward. That will actually open up the jugular foramen as well, and that can be, we can use that for stubborn cases. But again, the pressure is no more than you tolerate in your eyeball. Cranial work is light. So don't do any heavier pressure than that. The collarbone is another area where you can get an issue. And what we're looking for on these babies, okay, is, and I'm going to come back on off this again. So I'll stop the share so we can show you on this baby. Okay, so what we're looking for is we look at, I'm just going to take the baby's head out of the way. It'll look like something from The Exorcist, but it's not. Okay, we look for the heights of the clavicle. If you have an inferior medial clavicle, that's really very often where you get a problem with the vagus nerve. The clavicle going right inferior and down on the medial side. So to adjust that, you can literally use an activator on half a turn out just to lift it up, particularly if you've got a pediatric specific activator. And you can drop down the distal end. That can often help open up the clavicle. Or we just get our fingers behind the clavicle, do a slow stretch pull anterior, okay, and then a little fast stretch added to it. Very, very, very gently. But that can open up the clavicle as well, okay? So an inferior medial clavicle is the commonest lesion you'll see in that. We also get entrapments occurring around the diaphragm, okay? So as the vagus nerve penetrates the diaphragm, and that can often cause some of the visceral disorders that we see really commonly in babies. So what you're going to do with the diaphragm is you're going to palpate. We palpate along the inferior rib borders, and you're looking for any areas of tension. Okay, when you find an area of tension, and remember the baby's going to be supine, it's not going to be sitting up like this, but I can't show you with a supine baby. We're going to go in and we're going to slow stretch that area. I'm going to get the arms up. So we've got a little bit of tension on the right side of this diaphragm. We're going to go in and we're going to slow stretch. Okay, how long do we slow stretch for? About 5 to 8 seconds. And then we're going to do a fast stretch release where we pull apart. So it's literally pulling your fingers apart and leaving fast. So it's in slow. So you build up slow stretch, proprioceptive stretch, and then fast release. Okay, and that then the diaphragm sort of gets a little shimmy in it and come back down, and you'll feel the change in tension of the diaphragm. Okay, so we've got those 3 basic releases that I've covered. Okay, the occipital release, releasing that skull base. There, remember the test, flex it, feel the restriction, run away from the restriction, just go into the direction of freedom and follow it round. Okay, recheck, compare the other side, release both if necessary. Remember your sacral check, look for any deviation of the sacrum. If there's a deviation, you contact the opposite side of the deviation. So if the sacrum's deviating towards the left, in this case, you contact the right sacrum, you stabilize the right ilium, and we push the right sacrum, P to A, for about 5 seconds, followed by a fast stretch, reset it, okay? Then recheck, and you should get pliability there. You can also flex and extend this sacrum, okay? By squeezing together the ASISs, we flare the PSISs, and you can get hold of the sacrum there, and we can go base forward, apex forward, base forward, apex forward, base forward, apex forward. That ensures the reciprocity between the sacrum and the cranium. Really, we get a good pliability of those two. I can't emphasize enough how important it is to do the sacrum if you're doing the skull base. And then remember your other 2 entrapment points around that, the clavicle and the diaphragm. Okay, right, let me see if there's any questions coming through the chat. There are 3, what I can see. Do you think that this can also apply to the adults to balance the ANS? 110%, I do it all the time. It is really, really important to get use these techniques on adults as well. And you get adults who are way out of balance with their autonomic nervous system, asthma, chronic gut issues, irritable bowel syndrome, whole range of stuff. Really, really easy and straightforward to do on them as well. So yeah, these techniques are pediatric techniques, but they are also applicable to adults. Okay, yes, the question, first you do balance the sacrum before going up. My tendency would be, Jonas, I would balance the sacrum before going to the cranium, but as long as you do it on the same visit, it doesn't matter all that much. You just don't want to let the baby go without taking care of that sacrum as well. Thank you, Luke Ramsey. Very kind. Okay, balance sacrum before going high. Very good.
Hey,
Thank you.
Steve,
that's great.
maybe could you give us, in your experience, tell us, have you had any like unbelievable vagus nerve release experiences, like with kids, that you've seen like a real before and after, or like a big change, you know?
Okay, so if any of you done my seminars, you might have heard this one. This is the one I quote so much of the time. Yes, it could be loads I could talk about, but the one is a little girl who was 6 months old, and she fell off the bed onto her occiput and had a linear fracture across her occiput. And immediately after that started having watery diarrhea. Really, she had an incredibly quick transit time from food in to food out, and she was just pooing this watery, horrible stuff. And 3 weeks afterwards, the mother brought her in. She was losing weight, failing to thrive, and a whole range of issues occurring because of this. And I sort of looked at her and said, well, what's happened? Probably she's had an acute traumatic compression of a jugular foramen bilaterally from that fall straight onto her occiput, which is hard enough to fracture it. So we did an occipital decompression, a sacrum, an ear pull, a temporal release, temporal bone release, and she had a formed stool later that day and was then able to start eating food and stuff like that. So that was one of those one treatment wonders. They don't all happen like that, but this is when you free up that jugular foramen, if they're suffering from issues with it, that can be really, really important to normalizing their physiology. And it gets you into a whole range of areas, not just pain, but also areas linked to that visceral system.
Yeah, well, I definitely know too with the ear one. One of my associates did one of your seminars one time, and then when she came back and I got adjusted, she did the ear thing to me, and it was amazing. I was like, whoa, wow, that's just so, yeah. I recommend it in adults as well.
We've also got a question off Patrick. Could you use any type of neurological stimulation during cranial techniques? Oh, Patrick, yeah, I love the way you're thinking. Yes, we use a whole range of stuff. I look for hemisphericity, and then we stimulate the hemisphere that needs to go in, particularly in young children, less so in babies. Okay, in young babies, they're just forming, just adapting. But when we see a clear hemisphericity, one side weak, we will look at stimulating that with highlights or various noise or other things we can use to get that working. So yeah, indeed. And we can use any cranial technique with that as well. It can be very, very, very effective. Okay, I think we've covered all the questions.
I think so. And I think it seems like everyone did learn something over a webinar. So that's awesome. And thank you. Thank you so much for that, Steve.
My absolute pleasure. Thanks, guys.
I see as well that on your webpage, your courses, you're actually doing them online now, eh?
Yeah, we've got the Academy of Functional Pediatrics is the online thing we've got going. And yes, all my courses are on that, and people can certify in it as well.
Okay, great. Well, thank you so much for being on the call for us, Steve.
My pleasure, Erin. Thank you.
All right, the next in line, Anna.
Hello.
Hi, how are you?
I'm very fine, thank you.
And thank you for coming back. Number 2, round 2 for you. Yeah. So it's all yours. Go for it, Anna. Tell us about Atlas.
Well, it's all about Atlas, and it's a little bit misleading, the title, because I missed the second part of the sentence, and I would like to say that it's all about Atlas for me. When you offered me to talk about upper cervical, it's not that I told you I don't want to teach upper cervical, but I want to be completely honest. Guys, I'm not the typical upper cervical freak. I'm completely in love with the concept of upper cervical, but if you're all go like, you love this technique fights, you would not find somebody to fight about techniques with me. I'm in love with upper cervical, the upper cervical concept. And I have no clue how I'm going to be teaching technique in 15 minutes. But I want to tell you a little bit about what upper cervical means and why I don't consider myself an upper cervical freak, but why I think I am definitely a freak about the whole upper cervical concept, if that makes any sense. So BG talked about different levels of HIO practitioners, and I love that idea HIO being the hole-in-one, like being an upper cervical practitioner. And many years ago when I started my practice, 12 years, I'm quite young, especially comparing myself to Steve. And he gave the analogy of the ladder, right? Being in a ladder and different steps. I started, yes, with using instrumentation and pattern work from day one, the Titron infrared thermography, which helps us when to adjust an atlas and when to actually leave it alone. But I would check other segments too. And then according to BJ, I was going up the ladder, and 3-4 years ago, I started checking people. I kept checking people, but when the people were in pattern, which means they need to get their atlas adjusted, I only adjusted the atlas. And when they were not in pattern, which they meant they didn't need to get their atlas adjusted, I checked all the segments, what a mixer, with other protocols. What I mean when I say that I'm in love with the concept is because I learned from many masters like Steve and other people, other seminars, the concept of primaries, secondaries, and tertiaries. And I learned that, yes, there are primary subluxations, and then we have secondaries and tertiaries. And I learned that most of the painful areas in the bodies are normally related to the secondaries and the tertiary subluxations. So I wanted to have protocols that helped me find the major subluxation. And as a chiropractor, I wanted to being able to find, correct, and actually know when I had corrected that primary subluxation. And we are really lucky in this profession because there are people like, Clay Thompson or DeJarnette or BJ or Steve, and, like these really, really smart people that created protocols and that give us the protocols so that I didn't have to reinvent the wheel. And I've been teaching Toggle and Thompson at the PCC for many years, and I always tell them the same thing. I'm not here to challenge all those years and all those research papers that they publish. I choose just to copy what they found to be true. And if any of you at some point have those type of research papers and you find a protocol, I'll be the first one to learn from you. Like, that's why I learn from people like Steve and, like Carrick Institute or whatever, like I'm not here to challenge or like go into technique fights, but I definitely like the concept of upper cervical. Why? I'll tell you why. I tend to be very analytical and a very analytical person, and upper cervical offers me, first of all, an X-ray, and it gives me a listing. There are 12 different atlas listings, 6 different, especially with the Toggle analysis, 6 different C2 listings. So I don't have to think about contact point, segmental contact point, torque, patient position, where my episternal notch falls. I just go, draw some lines, and I know an A is array. So I just, with that X-ray listing, I know exactly what I need to do. It also gives me the instrumentation with pattern work. So I need to adjust or I don't need to adjust, right? Mm-hmm. And one of the biggest gifts of this is that it forced me as a practitioner to go really deep into the chiropractic paradigm, which I held true for me, and it forced me into being able to share with, and again, I repeat, it forced me to share something that it was true for me, which if it's not true for you, I completely understand. First one, it was about the patient being the superhero. So I was not doing the healing. The patient was doing the healing. They were expressing innate intelligence better. I was just removing subluxations. So they were the superhero. Second concept, it was about being adjusted not the adjustment. So it was about the whole process and not just the event. The important thing was not the adjustment, but what I was getting out of that adjustment, which it was accumulative constructive survival value. And you know, the difference between accumulative constructive survival value and accumulative destructive survival value. Those are the words that they used at the time in green books, but basically it was like, are we in healing mode or in destructive mode? And my goal was to educate patients that the body's either in constructive or in destructive mode, and being adjusted, put them on constructive mode. It forced me to help them understand that healing comes from the inside out, and that everything they can do, nutrition, exercises, functional neurology, getting adjusted, was not doing the healing, but creating an environment in the body so that the body could do that. Huge one. It made me go really deep inside to understand that the value on what I was doing was not in how much time I was spending with the patient, on how many vertebrae I was adjusting. That was huge, because sometimes, you know, an adjustment would take 10 minutes, and sometimes if I only do a vertebra, it's 30 seconds. But they were paying me for my expertise and my knowledge, not how much time they were spending with me. And with all the education that I was doing with the patient, it was like about long term. And I understand that different techniques can do that. What Steve just, you know, shared with us, which I have no doubt that Jordi would share with us, or SOT protocol or Thompson protocol. Definitely. But upper cervical did it for me. And honestly, when I asked myself why upper cervical, one of the major reasons is because I love getting my atlas toggled, and I love the concept of being upper cervically checked. For many years, I've only been checked like that, and I am okay when somebody tells me you are not in pattern, and I am okay if I have symptoms, you know, letting my body deal with that. You follow? Oh, good? Yeah, are you with me? Good. I see so many screens with names instead of faces. So to be completely honest, I faced, thank you, now I'm seeing a lot of faces, thank you. I saw, like, I had to face big 4 blocks. I know this is not techniques, but it's blocks related to technique, right? The first one, I named it before, which is related to money. How can I charge the same thing? Well, like sometimes I was blocking 20 minutes in a cut 1, and now it's like a 30-second adjustment. But again, I was willing to pay somebody that could rock my atlas instead of spending 20 minutes. I was not paying. I would pay Steve to pull on my ears for just 30 seconds so much, you know? I'd rather do that than pay somebody 30 minutes to rub my deltoid. You know what I mean? And I have nothing against rubbing a deltoid. But Steve is a freaking master. The second one, time. I don't know about you, but if somebody offered me a 1-minute CrossFit class, instead of having to do a 1-hour CrossFit class, I would sign up if they told me they had the same benefits. No doubt, no doubt. In 1 minute, and again, all techniques work, right? We have like amazing research on incredible results from DJarnett or Clay Thompson or Steve or like BJ, like the masters. So all techniques work. So why not trust that toggle? And I did in 30 seconds. It works for me. So it wasn't a time thing. And again, I would definitely go to a 1-minute CrossFit class. I know it doesn't work like that, but techniques, we have that results. Then another block was, do I have the ability and the certainty and the tools to educate my patients? Like, are they going to stay if I start adjusting just Atlas? And the fact it pushed me to be a better educator and a better communicator, and it pushed me to create a lot of education material. And also it pushed me to, well, pushed or it forced me or like whatever in a very loving way, but to have more conversations on a table talk, like every single day with their symptoms. Because don't you think that in my practice, everybody's like, oh, I need an atlas. That's fantastic. I don't care about my hernia. No, they do. And they ask me. So every day I have to go into, do you understand that this is a compensation? Or, I'm sorry, do you need a hug? But my job is done. Like, I'm pretty sure, sorry for the example, but I understand, or I'm pretty sure my dentist feels sorry for me when I have diarrhea, but I would not tell them, or they're not going to take care of my diarrhea. So I don't feel responsible when they have some type of pain. My job is to locate and correct subluxations. Again, this is my take on this. So yes, I have created the tools for location, correction, and knowing if I have corrected the subluxations, which is the way I see my job. And I chose Atlas. I not only do Atlas, when my Atlas is done, I have other protocols, which I have chosen Thompson, because again, Clay Thompson said, heat them high, heat them low, let them go. I know the science, dentate ligament, brainstem, vagus nerve. Steve did a great explanation of it. I know the relevance of the science, but I don't go crazy about it because it's not my thing. I go crazy about communicating our paradigm, which is what really turns me on. And there are so many things you can learn apercervically and how to master that technique. I am in love with the toggle adjustment, and this is what has worked for me. But I have no doubt you can apply all these things for any like other techniques. No doubt, no doubt. And I was thinking about another major challenge within general techniques when you focus on subluxation correction is that probably, I don't know if you face this, but also you have the challenge of like, do I really trust that innate, that healing ability? Is like, do I feel forced to do more to help with the process? And that was a tough one for me too. And then I realized sometimes in the body less is more. And I was not thinking about this, but somebody asked Steve, no, I think Aaron asked Steve, like one of these one-time adjustment wonders. And I had so many just with an Atlas. It's insane. Like frozen shoulders, one toggle, gone. L5, S1, disc issues, I cannot walk, gone. Like crazy stuff, but it's not crazy. It just reminds me of what the body is able to do. And the only thing, it's for the analytical people, knowing exactly when to touch and when to leave it alone is just fantastic and very, very important, empowering for the patient when they actually understand that it's their body doing that. It's fantastic. It's fantastic. I don't want to become the superhero, but again, this is me. It doesn't have to work for you. Cool. But basically, now I can do a little bit of a technique teaching. Upper cervical, sorry for the speech, but upper cervical is based on X-ray, very specific, Titron, kind of like Gonstead with a nervoscope, but Titron is infrared thermography. It measures skin temperature that's regulated by the autonomic nervous system. So the pattern is established in the first visit. Basically, I had a picture about technology problems during lockdown. I cannot show you, but basically everybody has a line, like the shape. Mine is like an S. So everybody, and I got that line when I was in pattern before I ever got adjusted. So my line looks like an S every time I need an adjustment, which means my nervous system is not able to adapt. My line would look like an S. Any other time that my body is actually adapting, my nervous system, it's different, it would look like a different line. So it means I'll leave my atlas alone. And I do that for every single patient before an adjustment. If they need an atlas, I adjust the atlas and then I let them rest for 5-10 minutes. And then we scan again. And if I have done a proper adjustment, the line would look different, which means they are adapting again, which means they're healing because their nervous system is doing what it's supposed to do. And that gets me very excited. And then I share that excitement with them. And that's it.
Mm-hmm.
That was probably more than 15 minutes. I'm sorry.
But it's interesting to what you're saying now. And I mean, I don't know how everybody else is feeling, but I suppose because we are at home and we cannot adjust, I suppose it's a really great moment to reflect on how we want to adjust. What is it that we want to do? What is it that turns us on? Like you say, what's your favorite adjustment? You know, what's your favorite thing?
Yeah, I think we all choose a technique and sometimes we don't really think why. And that's a question I ask myself when you ask me to do this, because I'm not trying to convince anybody to go into upper cervical mode. If it's the right thing for you, I'll be running a Trogel workshop really soon. And I'll teach you how to, you know, do the setups and do the X-ray listings and what pattern work is. That's fantastic. But it doesn't have to be for you. But ask yourself, why do you use certain techniques? I mean, great answers always come with the question, why?
Mm-hmm.
So,
yeah. Okay, well, thank you so much, Anna. Thanks for your insight about Atlas.
You're welcome.
Yeah.
A pretty cool vertebra.
Yeah. Jordi and Co. Who's going to do the talk today, Jordi? You or your little daughter?
I'm going to leave the baby back. I'm with you, Barbara. That was for the practical with Steve.
Yeah,
the real one.
Okay, Jordi, so our third speaker for today, and it's all yours. Go for it.
Okay, I'm going to share the presentation. I'm just going to see the chat on a side so I can see the questions. Okay. Could you see the presentation?
Yeah.
Yeah, okay, good. So you all will get the PDF in the website. Erin will tell you where to find it, or you will just see the link after. Mm-hmm. Well, basically for functional neurology, also in a short period of time is a tough topic, but I'll try to do my best so everybody could get something from this presentation. And my idea basically was to teach precisely some tips for the, let's say, the average chiropractor, not necessarily being a functional neurologist. So things we can use in most our offices. The idea basically here is to start with some neurological indicators, and then few of the ones I chose here that I think a lot could use. Maybe some will decide, well, I'm not gonna use an optokinetic tape, but if you have, you can. I maybe wanna use the eyes because that one is an easy one. I just need to check pupil size, both sides, see if there's a difference in between one side and the other. The importance of that will be that the dilated pupil will be in several cases related with an increase in pathetics. There could be also other causes, like even a genetic cause. So we need to know if that has been there forever or not. Posture, I'm using here the word body language. This word comes from applied kinesiology. And as the example I added here, basically is when we look at the posture from an applied kinesiology perspective, we can correlate that abnormalities we find in the posture with some weak muscles. So that's something I always add to this. So meaning, for example, I could see an elevated shoulder and think, okay, maybe it's due the inferior trap on that side that could be weak. So I'm maybe gonna go and check that muscle, or could be the latissimus dorsi on the same side, or could be the contralateral upper trap, for example. The concept of extrapyramidal weakness pattern, that's one of the main and basic ones in functional neurology related with the concept of hemisphericity. And it's basically a soft weakness compared to the spastic one, but the affected muscles are the same. So basically we see an increased tonus of the flexor muscles, anterior shoulder position, increased elbow angulation, and the lower extremity tends to move outwards. Okay, that's the typical extrapyramidal weakness pattern. The difference with a severe cortical lesion, for example, from a stroke, is that in those cases it will be contralateral, the affectation in the body, in those muscles, and the tendency will be spastic. Whereas in extrapyramidal affectation, it will be ipsilateral affectation of those muscles to the cortex that has a decreased frequency of firing. Then another easy one will be the Romberg's. I don't think I need to talk about what the Romberg's is. Palatal paresis, which is basically a soft palate. We can ask the patient basically to say, ah, look at the mouth. We can use a pen light, even the light from the phone, and see if there's the uvula here. I try to represent it with my hands. If you have the uvula here, as in this picture, and then the soft palate on each side, and see that at the moment they say, ah, one is hanging down more than the other. It's not elevating. There's a type of paresis, weakness. And usually we find this also in the same side of the hypofunctional cortex. Then in general, I recommend to check some indicators of proximal or distal weakness, so we get an idea if in this patient we find some distal muscle affected or proximal ones. And again, another one will be the pain pattern, as we use, for example, in the pelvic categories or any other, according to the presentation of the patient. In here, you also have some summary about what I said. Romberg, for example, in general, it points to the hypofunctional cerebellum, the initial sway. Ipsilateral paresis to the hemisphericity side. And then, for example, if we use an optokinetic pan, that we may want to use an app with the phone, there are many of them. And if you see me in the camera, I can use this type of application and then just place it in front of the eyes of the patient and look at the ambulational movement of the eyes following the tape and then a refixation saccade. The main idea about this is that the direction of the tape stimulates that side of the cortex and the opposite side of the cerebellum. So basically the pursuit goes towards the cortex and the saccade goes towards the cerebellum. So we can use also as an application this for home exercise to the patient to improve the stimulation of that side of the cortex or the cerebellum. A few other points that I consider important is that for the extrapyramidal pattern of weakness, in general, hemisphericity is gonna cause some weakness of the opposite muscles of that posture. So if the anterior muscles have an increased tonus, then the posterior ones are gonna be weak, and opposite muscles have or in the lower limb. This is going to be also related with the adjustments we do for the extremities, the fast stretch we do for these muscles with an increase of the tonus. Then other important points is that, for example, if we decide to do some muscle testing, proximal weakness is more commonly associated with cerebellar problems. That's due the pathways that are affected. So there are some vestibulospinal pathways and rubrospinal pathways in which there's an important role from the cerebellum. And then, for example, in cortical dysfunctions, distal weakness, it's always gonna start before proximal one. So then we tend to check first the hands, the fingers, the wrist, before shoulder or hips. If you find, well, you can use the OPK, one of these apps. For example, one simple application you may wanna try in your office when you can work with patients, or if you're already doing, is that you can ask the patient to hold this OPK with this app towards one direction or the other, towards the left or right. And then you can use, pick one of the weak muscles you found and see if one direction strengthens. So that will be the direction you wanna use for the patient to train at home. If you don't find a weak muscle, or you just work with a strong indicator muscle, meaning a muscle in which you don't see any dysfunction, what you could do is use the tape and try to find if that weakens a muscle. But what I can tell you is that most times it's only gonna cause the weakness precisely in muscles that could be partially affected. So either proximal or proximal or distal ones, and many times only on the affected side, meaning the side of the hypofunctional cerebellum or the side of the cortical dysfunction. So you'll need to try. So it doesn't. So if you do this with the tape and it doesn't weaken a muscle, it doesn't mean anything just with that. So there could be a lot of false positives, false negative. Then few other points here. Is there any question there? I need to. Is any soma similar to nystagmus? Any soma similar? I don't understand the question. Soma similar? Well, if I can maybe reformulate the question because I don't understand it. I continue with the presentation. For cervical adjustments, which is going to be the next slides, some tips for that. In general, if we get some indicators of hemisphericity, again, which means a decreased frequency of firing of an hemisphere, the left or the right hemisphere, and we consider this because maybe we found this extrapyramidal weakness pattern, or we found this distal weakness, and maybe anisocoria, increased sympathetic on the same side, pain patterns, the tender is more on that side of the body, which is typical in these cases. Then when you want to adjust the cervicals, in general, it's better to try to find the subluxation on the opposite side of the cervical spine, of the cortex you want to stimulate. The first one who started this and published a study in 1997 was actually Ted Carrick, and he did a study with the blind spot and adjusted basically C2 on the opposite side to everybody who had an hemisphericity according to where the bigger blind spot was. Let me see the questions in the chat. How often would you recommend them to do tape at home, and what duration? Okay. And another one is asking for the OPK app. OPK app, Optodram is a good one. Yes, there's another one. It's called OKN strips, optokinetic strips. That also works, and I think right now you can find both in for iPhone and Android. How often? I recommend them to do it daily, at least 3 times per day. And then usually I check at my office the time that it's not causing fatigability in the movement. They don't get dizzy, they don't get any nausea or any reaction. And for example, if I do it several times and they get any reaction, I try to do the time of the training a little bit shorter. In general, I will say maybe 20 seconds of movement, 30 seconds rest, and repeat it maybe 3 to 5 times. That will be a set, and I will recommend it to do maybe 3 to 5 times per day. Okay. Good. Well, if you want to use functional neurology, it is really important that you pick any of these indicators. That's why I started just listing several of them, and then to recheck if there's any improvement. So get the positive ones. You don't need to go through all of them. So if only you found some swaying Rombergs, or you found a dilated pupil, or a soft palate that was lower than the other, just go and recheck those after the adjustment to see if the central integrative state of the patient is getting any better. So the integration to all these stimuli. I didn't do that drawing, by the way, in the screen. Let me see. Not on purpose. Okay, tips for cervical adjustments. Few things you can do at the same time you adjust the patient. You pick the head and you want to adjust them. One is you can ask them to do a saccade, so just move the eyes opposite contralaterally to the cortex you want to stimulate. So let's say there was a right hemisphericity, you found that extrapyramidal weakness on the right side, dilated pupil on the right, so you want to stimulate the right cortex. You're going to do the couple adjustment anterior to posterior from the left side. And then when you want to adjust the patient, you're going to ask the patient to just move the eyes towards the left. That will be a saccade contralateral to the cortex. One nice way to do that is, as the patients most times are going to be in supine position when you do this adjustment, is to place some stickers in the ceiling. Okay, you can place some stickers there, and maybe one of them is a star or a circle. So you can say, okay, start looking at the circle, and then when I tell you, look at the star. And then when they move the eyes, you're going to do the adjustment at the same time. So this way, there's going to be a summation of neurological stimuli to the brain. Okay. Oops. 1 second. I want to come back to that. Okay. Questions. Will you address more the lateral flexion or the rotation for cervical adjustment? Well, when I do a couple adjustment, I address much more the lateral flexion than the rotation. So basically, I just get the tissue slack A to P with the thumb or with my index finger, get the tension there, and then the movement is basically going to be a fast stretch from the muscles of the opposite side of the neck, and then it's going to be, there's going to be a line of drive A to P, but I'm not going to cause much rotation there, but fast stretch lateral flexion. Another thing you can do that I do quite often, that's what I also introduced the OPK, is that you can ask the patient, for example, to hold I have an iPad or the phone, to hold the phone and with the tape moving in one direction. Let's say you found that moving the tape towards the left was strengthening a muscle. So, or you found just the indicators with again, the palatal paresis or the anisocoria on the right side. And you say, okay, I want to stimulate with the tape that side. So that means moving the OPK tape towards the right. And then I'll ask the patient to hold the iPad while the tapes are moving rightwards. And then I'm going to perform my adjustment at the same time they're doing this. And again, it's another way to get further integration and more summation of stimuli to the brain. Plus, with all these tricks, The good thing is also it's easier to adjust because it's causing like a Gendrastic maneuver, some distraction. So they are not that much aware of the tension of the neck, for example. So that helps adjusting them. Another one, if we use the couple cervical adjustment, will be asking the patient to push towards the contact hand. So if I'm holding the head and I'm adjusting with this hand, the patient is just gonna push with the head towards my hand. And at the same time they pushing, then I'm gonna adjust. And that facilitates the movement. That's another good one. For hemisphericity, would you adjust cranial bones like sphenoid bone for cranial nerves? Well, of course, as but it was too much to talk today. So yeah, I will do it. If I, in general, I address the cranium. If I see any indicators that there's any cranial fall in there, I'll do it for sure. Okay. Other tips for rib adjustments. Well, we know when we perform rib adjustments, that's a really common adjustment in functional neurology. Sometimes it's the first one we do to the patients, just standing before they lay down in the table, because it improves the oxygenation to the brain, okay? And in general, it causes a nice release of the thoracic area. This standing adjustment, which I think I added just a picture of just to get the idea of the position, okay, and the contact hand in here. I'll use the thinner pad in the rib as a contact hand. The movement consists basically of a coordinated thoracic extension of the chiropractor with a bilateral activation of brachioradialis. What it means, so if I'm in this position, if you look at me in the camera, what I'll do is basically bring my thoracics in extension to adjust it. So my main movement is this one. And then I do it together with a little bit of movement of this. So the activation is of these muscles, of the brachioradialis. A little bit of this, just a little bit, and then the rest comes from the chest movement. Okay. And I recommend to assess chest expansion before the adjustment, compare both sides, also compare the lower ribs if the expansion is the same one side of the other, because otherwise it means most likely there's some problem of the diaphragm, as Steve was talking before. Then to do a diaphragm release will be a really good thing to do before these rib adjustments. And as I wrote here, I think I wrote it anywhere. Well, quadratus lumborum, psoas, and diaphragm, missing here, will be the main common causes that will perpetuate a fixation of the inferior rib cage. So I recommend to assess this if you always see the patient with problems in the thoracolumbar junction. Also, maybe a tip some of you didn't know, one of the causes that could perpetuate a first rib subluxation are flatulence. Okay, when patients had a lot of flatulence from the pressure it causes, we tend to see repetitive chronic first rib subluxations. So ask that for the patient, and if that's the case, try to address the gut. Then intercostal space tenderness is helpful to determine the position of the subluxated rib. That means, if you look at me, if you have the ribs here, and then you have the intercostal space in between the ribs, first you start finding which is the subluxated rib. Usually it's a little bit more anterior and tender. So the costosternal junction is usually more tender in that one. Then you're gonna see the intercostal space. If then this one is the affected one, let's say, if the intercostal space, the superior or the inferior, are more tender. So if this is a subluxated rib and this one is more tender than this one, it means the rib is gonna be in this position. So these muscles in here intercostal muscles are contracted, causing more tenderness here. And if this one is more tender, it means the rib is more in this position, so it will be inferior or superior.
Mm-hmm.
Okay. And then I added just something for the TMJ. In here it says TMJ dysfunctions affect the posture and gait. So when we have TMJ problems, the main thing I'm gonna be concerned about the TMJ is when I see somebody walking and they don't have any arm sway. So they walking and the arms are like a stock. One of the main causes for that are descending problems from the TMJ. And also other type of posture problems. There's a lot of articles showing the relationship in between occlusion problems and posture abnormalities. Questions, let me see. Okay. Oh yeah. It was an answer. It's one of the question. It was an answer.
Do you get, are they audible releases that you're getting as well from the ribs?
If I get an audible, you said?
Yeah, with those rib adjustments.
Yeah. Most of the times. Sure. Yeah. There's a nice audible in most of the patients. Okay. I tend to do it standing. As for everything, the more you do and the better your technique, you are able to do it standing with most part of the patients, even if they are big ones. It's about letting them lay on you, and then you can do the movement. And in others, maybe I sit them in the table. I just avoid this in really elder, especially women, for the risk of fissure or fracture. And then I use the activator. Okay, TMJ. Okay, do you ask them to look up as well during adjustment of ribs? Yes. So if the rib, for example, is let's say inferior in the previous example, and I'm gonna adjust in that position from inferior, so it's gonna be a movement, a contraction of my brachioradialis, extension of the thoracics, and there's gonna be a line of drive A to P and inferior to superior, according to that. And in this case, if the rib is inferior, as when we breathing in, the ribs move from inferior to superior, I'm gonna ask the patient to breathe in at the same time I'm adjusting him. And also, when they are lying down on me backwards, I will ask them to look upwards, okay, at the same time I'm adjusting them. If the rib is subluxated superiorly, as I cannot push it down this way when I'm adjusting, I'm basically not gonna do the movement inferior to superior, but A to P, and I'm gonna use the breathing pattern. Basically ask them to breathe out at the moment I'm adjusting to help for the movement of the rib during that phase of the breathing. Otherwise, I'll use just the activator with the phase of respiration needed. Do you adjust also posterior ribs? Yeah, I'm not covering posterior ribs, but yeah, I do it. Yeah. Okay, TMJ. It's common to find, and there are articles showing this, that it's common to see when there's an occlusion problem to find a weakness of the mid-deltoid, okay, and or neck flexors. So this will be main muscles I will test for TMJ abnormalities. Check the sternocleidomastoid and test the mid-deltoid, okay, and recheck. And then I will see if I found a weakness of any of those muscles, if there's a different jaw position that strengthens that, okay? And basically in here you see the direction of the drive for the TMJ adjustment. And I think I'm already out of my time. So if you have any last question, or I give the speak to Erin to finish it.
Sorry, can you show me the TMG, just like explain that little one again, the TMG one?
Yes, so basically, so contact point, this will be the hand that adjusts it. So it's going to be in a diagonal, let's say towards the contralateral nipple. Okay, that will be my line of drive. What I'll try to do is, before adjusting it, try to be sure, if you look at the camera, if you can see me, that the mandible, okay, it's really loose. So I need to be able to clench their teeth passively. So to do this, if I cannot move it, I'm not gonna thrust on that mandible. So I'm gonna be sure that I can do that. At the moment I can, then I'll do the thrust. And then what I wrote there is I can use the same type of tricks as for cervical adjustment with the eyes.
And do you even find with your TMJ, do you get an audible with that one as well?
Yeah. It gets the same audible or even more than any cervical adjustment.
Okay.
Yeah.
And what about you, Jordi? Tell us some interesting case of yours that you've had too come into your practice. Like you see a lot of people with different neuro issues and some really good cases that you've had.
Yes, let me think out one just to share. Okay, for example, about this TMJ, just talking about TMJ as I have the TMJ in front of me. As I said, TMJ is quite often related with gait abnormalities and difficulties for arm movement. And basically, one of the patients I had last year, I actually commented it in a lecture, I think this week or last week with BCC students. She was, she's a girl, a teenager, around 15, 16 years old. She's the daughter of a friend in Holland, and I moved there because I was gonna teach a seminar for brain and neuroplasticity. And when we finished it, my friend Jay Postma told me, okay, I have the daughter of this friend who is having these asthma episodes or epileptic episodes. Well, actually, the medical doctor doesn't know actually what's going on with her. The problem is that she cannot breathe for short periods of time, and she gets like anxious. She gets up from the bed because of this. So first they thought it was asthma, then they did the test, so nothing positive for asthma. They also checked if there was some kind of epilepsy, but also was negative. So they didn't know actually how to address that, but it was just getting worse, okay, more often. And then they were saying, okay, maybe it's psychosomatic. You know, when they don't know where to find, it's always psychosomatic, which could be because we all know that emotions could really affect most things. But actually, I was talking with the girl, and it seems there was she was looking like a happy girl, nothing like affecting her so much. I was trying to talk with her in private, like, okay, tell me, is there anything that it's triggering this when you have more episodes, any problem you have at the school or anything? Nothing. And then the only thing I found in her history was that actually a week and a half before all this started, she had dental orthotics. And then I started moving from that hypothesis, and what I found with her was that the cruciate suture, the one in between both palates, was shortened. Okay, and in general, when that happens, from the affectations it has to the cranium, one relationship we see is with the sagittal suture and with the pubic symphysis. And then what I found, knowing this from AK, was that the adductors were really tight on both sides. And when I asked her to just release the cruciate suture, separating it, the range of movement was increasing a lot in these adductors. So then I got a positive indicator that something was going on in there from these orthotics. So I recommended her to do the spreading of the suture several times while she was breathing in. And I checked a few other indicators. That was the only one consistent neurologically. So I recommended to do that several times per day. And after a week, the number of episodes were getting way better. So at the end, their parents decided to remove the orthotics. And once they removed the orthotics, I think it doesn't even last 2 weeks, and she had no more episodes at all.
Wow. Amazing, no?
Yeah, sometimes it's like one few thing that it's just altering the input to the brain, and in the TMJ we see a lot of these things.
Yeah, for sure. Okay, well, thank you. Thanks, Jordi, for that, and thank you for all those tips. I mean, there's heaps of them there. So I'll put that PDF in the Chiro chats group so everybody can have that too. You know, and then when we can go back to work, we can print it out and use it in our offices. Yeah.
Okay, thank you for the invite.
Thanks, Steve, and thanks, Anna, for being on the call. I've got another one organized for Monday night at 7 o'clock if you guys want to register for that too. Okay, so thanks everybody for being on the call. See ya. Bye.